Some body quirks look harmless until they start stealing the small things first. A full breath, a quiet night of sleep, a painless walk, a word that comes out clearly. And the strange part is, it can begin with something so small you barely notice it. Deviated septum. You think one blocked nostril just means allergies, a cold, or sleeping weird. Sometimes, nope. Deviated septum is when the wall inside your nose, the cartilage and bone that separates the left side from the right side, sits off-center. Not dramatically. Not like your nose is waving a tiny red flag. Just enough to turn one's nasal passage into a narrow hallway during rush hour. And here's the annoying part. You can live with it for years and just think, I guess this is how breathing works. It isn't. Your nose is supposed to filter, warm, and humidify air before it hits your lungs. But when one side is crowded, airflow becomes uneven. One nostril works overtime. The other one becomes a decorative tunnel. You notice it at night. You lie down, one side plugs up, your mouth opens, and suddenly you're sleeping like a dried-out goldfish on a pillow. Then morning comes. Dry mouth, headache, maybe snoring. Maybe that feeling that you slept 8 hours, but your face somehow did cardio. The trap is that people blame everything except the structure. Blame dust. They blame weather. They blame bad sleep. And sometimes those things are involved. Allergies and sinus issues can make symptoms worse. But if the wall itself is crooked, sprays may calm swelling. They don't magically move cartilage back into place. The fix is not to panic and diagnose yourself in the mirror like a bathroom detective. If it causes no symptoms, it may need nothing. If breathing problems, chronic congestion, nosebleeds, facial pressure, or sleep issues keep showing up, that's when an ENT doctor can actually look inside and tell you what's going on. For severe symptomatic cases, septoplasty is the surgery used to correct the septum, but that's a medical decision, not a YouTube comment section decision. Your body may not be lazy. Your nose may just be built like a hallway with furniture in it. Preauricular pit. That tiny hole near the front of someone's ear looks like a failed piercing. It's not. A preauricular pit is usually something you're born with. A small opening in front of the ear that connects to a little tract under the skin. Think of it like a secret tunnel that the body started building during development, then forgot to close properly. Most of the time, it just sits there doing absolutely nothing. No drama, no villain origin story, just a tiny dot minding its business. But here's where it gets interesting. The visible hole may be tiny, but the tract underneath can branch or twist under the skin. So the part you see is the front door. The part you don't see is the weird hallway behind it. And hallways can trap things. Dead skin cells, oil, bacteria, tiny biological junk mail. When that happens, it can swell, hurt, turn red, drain fluid or pus, or form a small cyst or abscess. That cute little extra hole suddenly becomes an angry button next to your ear. Picture a kid named Leo. His parents notice a tiny dot near his ear when he's a baby. Nobody worries. Years later, it gets red and painful after a few days of irritation. Everyone thinks it's a pimple. But a pimple doesn't usually come with a hidden tunnel system. That's the twist. Most preauricular pits are harmless and don't affect hearing by themselves. But doctors still pay attention because, rarely, pits can appear with other ear, kidney, or genetic-related findings. That doesn't mean every ear pit is dangerous. It means context matters. One tiny dot is not the whole story. The fix. Don't squeeze it like a pimple. That's how you turn a small problem into a tiny crime scene. If it's calm, it may not need treatment. If it gets swollen, painful, red, drains pus, or keeps getting infected, a healthcare provider can treat the infection, and recurrent cases may need complete removal of the tract by a specialist. It's not a piercing. It's a leftover blueprint from ear development. Tongue tie. You think the tongue is just a floppy little food shovel. Nope, it's a precision tool. A tongue tie, or ankylosing, happens when the band of tissue under the tongue, called the lingual frenulum, is unusually short, tight, or thick. That band can restrict how far the tongue moves. And that matters more than people think. Your tongue helps with breastfeeding, swallowing, speech sounds, cleaning food off your teeth, and moving food around your mouth without turning dinner into a mouth-based escape room. When the tongue can't lift well, move side to side, or stick out past the lower front teeth, the body starts improvising. Babies may struggle with feeding. Older kids or adults may notice speech difficulties, tongue movement limits, or a tongue that looks heart-shaped when stuck out. That heart shape sounds cute. It's not always cute. Sometimes it's a sign the tongue is being pulled down from underneath, like a kite tied to a fence. Here's the part people get wrong. Tongue tie is not automatically a disaster. Some cases loosen over time. Some persist, but cause no real problem. And not every baby with a tongue tie needs a procedure. That's the nuance. And nuance is where the internet usually crashes into a wall. One side says cut every tongue tie. The other side says ignore all of them. Reality is more boring and more useful. Treat the problem, not the label. If a baby is feeding well, gaining weight, and the parent isn't having major feeding pain, doctors may simply monitor it. If there are real feeding problems, speech concerns, or functional limits, professionals may suggest support like a lactation consultant, speech therapy, or in some cases, a procedure such as frenotomy or frenuloplasty. The fix is not fear, it's function. Ask, what can the tongue actually do? What can it do? And is that causing a real problem? Because the tongue may be small, but when it's restricted, the whole mouth starts negotiating with a tiny piece of tissue. Micrognathia. A small chin can look like a facial feature. Sometimes it's more than that. Micrognathia means the lower jaw is smaller or underdeveloped. In babies, this can matter because the jaw is not just there to shape the face. It helps make room for the tongue, and when the lower jaw is too small, the tongue can sit farther back than it should, like furniture shoved into the wrong corner of a tiny room. That's where the problem begins. The face may look calm from the outside, but inside the mouth, space is being negotiated. The tongue, airway, feeding, and jaw are all trying to share a room that is too small. In mild cases, a child may grow, and the jaw may catch up over time. That's why micrognathia is not automatically a disaster. Some babies improve as they grow. But in more serious cases, the small jaw can affect feeding and breathing. A baby may struggle to nurse, take a long time to feed, gain weight slowly, or have breathing problems during sleep. Picture a newborn who keeps falling asleep while feeding. Everyone thinks, cute, sleepy baby. But the real issue may be that feeding is hard work because the tongue and airway are fighting for space. That's not laziness. That's anatomy. And here's the deeper twist. Micrognathia is often not the whole diagnosis. It can appear as part of several craniofacial or genetic conditions, so doctors don't just look at the chin. They look at breathing, feeding, the palate, growth, and sometimes the airway during sleep. The fix is not staring at a baby's profile and panicking. The fix is function. Can the baby breathe safely, feed safely, grow properly, sleep without obstruction? Mild cases may only need monitoring. More serious cases may need feeding support, sleep positioning under medical guidance, airway support, orthodontic care later, or surgery in severe cases. The jaw may be small, but the consequences are not always small. Forward head posture. You think you're just checking your phone? Your neck thinks you're carrying a bowling ball with bad management. Forward head posture happens when your head sits too far in front of your shoulders instead of stacked over your spine. It's the classic tech neck position, chin forward, shoulders rounded, upper back curved like your body is slowly turning into a question mark. Long screen time and leaning toward monitors can encourage this posture. And here's the part people miss. Your head is heavy. When it sits over your spine, your body handles it well. But when it drifts forward, your neck muscles have to work harder to hold it up. It's like holding a grocery bag close to your chest versus holding it straight out in front of you. Same bag, different suffering. Over time, this can be linked with neck and shoulder strain, back pain, reduced neck movement, and headaches in some people. Research has also found associations between forward head posture and neck pain or reduced cervical range of motion. Picture someone named Maya. She sits at a laptop all day. At first, nothing hurts. Then her neck gets tight. Then her shoulders burn. Then she starts massaging the same spot every night like she's trying to erase a curse. The curse is not mysterious. It's load. The head moves forward. The neck muscles become overworked. The upper back compensates. The shoulders creep up. And suddenly your body has built an entire office chair survival strategy. But here's the nuance. Posture is not morality. Sitting badly doesn't make you lazy, broken, or doomed. Bodies are adaptable. The problem is not one bad posture. The problem is staying frozen in one position for hours. The fix is not walking around like a royal guard with your chin glued back. The fix is movement and setup. Bring screens closer to eye level. Take small movement breaks. Strengthen the upper back and deep neck muscles if a clinician or physical therapist recommends it. Let your body change positions before discomfort has to scream for attention. You don't need perfect posture. You need a neck that isn't doing unpaid overtime all day. Cervical rib. A rib in your neck sounds like anatomy made by a tired intern. But it's real. A cervical rib is an extra rib that grows from the cervical spine, the neck part of the spine, usually above the first normal rib. Many people who have one never know it's there. It can sit quietly for years like a weird bonus part the body installed and forgot to mention. But the neck is not empty space. It's a crowded highway for nerves and blood vessels traveling between the neck, shoulder, arm, and hand. And when an extra rib takes up space in that area, it can sometimes compress those structures. That can contribute to thoracic outlet syndrome, a group of disorders caused by compression of nerves or blood vessels in the lower neck and upper chest. That's the twist. The problem is not the rib itself existing. The problem is what the rib might crowd. Symptoms can include pain, numbness, tingling, weakness, or changes in the arm or hand, depending on whether nerves or blood vessels are affected. Some people may notice symptoms when lifting the arm, carrying bags, or holding certain positions. Imagine carrying groceries and your arm starts tingling. You shake your hand. You blame sleeping wrong. You blame your keyboard. You blame the grocery bag for being dramatic. But sometimes the bottleneck is higher up, near the neck and collarbone, where nerves and vessels are trying to pass through a crowded anatomical tunnel. And here's the important part. Most people do not need to hunt for extra bones just because their shoulder hurts. A cervical rib only matters medically when it causes symptoms or contributes to compression. Diagnosis usually needs proper medical evaluation, sometimes imaging, and a clinician who can tell the difference between muscle strain, nerve irritation, vascular symptoms, and actual thoracic outlet problems. The fix depends on severity. Physical therapy may help when symptoms come from nerve compression. Medicines may help discomfort. Surgery to remove the cervical rib is usually reserved for cases where symptoms are significant or thoracic outlet. Syndrome needs decompression. So, no, your neck is not supposed to have a bonus rib. But if it does, the question is simple. Is it just sitting there, or is it stealing space from nerves and blood vessels? That's the difference between a weird X-ray finding and a real problem. Pectus Excavatum. There's a version of this where someone avoids the swimming pool, not because they hate water, but because taking off a shirt feels like stepping onto a stage. Pectus excavatum is when the breastbone sinks inward, creating a dent in the chest. Some people call it funnel chest, which sounds like something a pirate doctor invented. But the idea is simple. The front wall of the chest grows inward instead of sitting flat. Cleveland Clinic describes it as an abnormal development of the breastbone that creates an indentation in the chest wall. And here's the part people miss. This is not always just cosmetic. In mild cases, it may cause no physical problem at all. The person just has a different chest shape. That matters because not every visible difference needs to become a medical emergency. But in more severe cases, the sunken chest can reduce space inside the chest cavity. The heart and lungs are not floating in an empty warehouse. They live in a crowded apartment. Push one wall inward enough, and suddenly the furniture has to rearrange itself. That can show up as shortness of breath, chest discomfort, reduced stamina, or feeling more tired during exercise. Some people also carry the emotional side. Hiding their chest, avoiding sports shirts, standing with rounded shoulders to make the dent less visible. The body changes the posture to protect the confidence. That's the quiet part. Sometimes the chest wall isn't just affecting breathing. It's affecting how someone enters a room. The fix depends on severity. Mild cases may not need surgery. Exercise and posture work may help strength, mobility, and confidence, but they do not magically pop the breastbone outward. More serious cases are evaluated by specialists, and surgery can be considered when symptoms or severity justify it. Cleveland Clinic notes that open or minimally invasive surgery can treat Pectus Excavatum, while mild cases may not need surgery. So don't reduce it to just a dent. Sometimes it's anatomy. Sometimes it's stamina. Sometimes it's years of someone pretending they don't care. Mild scoliosis. What if your spine is not straight, but also not necessarily broken? That's the weird middle ground people misunderstand. Scoliosis means the spine curves sideways. Mild scoliosis usually means the curve is small, often found during growth, a school screening, a doctor visit, or an X-ray done for something else. The shock is that many mild curves do not cause dramatic symptoms at all. No lightning bolt pain, no villain music, just a curve quietly existing in the background. The spine is not a metal pole. It is a living stack of bones, discs, muscles, and nerves trying to balance a moving human. A small curve can be like a road that bends slightly through a hill. Not perfectly straight, but still usable. That's why doctors often watch mild scoliosis instead of attacking it immediately. AIO says that if a child's spinal curve is less than 25 degrees or the child is almost fully grown, doctors may recommend observation and follow-up checks to see whether it worsens. The scary part is not always the curve today. It's whether the curve is progressing while the body is still growing. That's the open loop parents panic over. Will it get worse? And the honest answer is, sometimes yes, many times no, and that is exactly why monitoring matters. Picture a teenager named Evan. His shirt hangs a little unevenly. One shoulder looks higher in photos. His parents spiral into worst-case scenarios. But the doctor measures the curve, checks growth, and says, "We're watching it." That sounds passive. It isn't. Observation is not ignoring. It's surveillance with a clipboard. For some growing children with moderate curves, bracing may be recommended to reduce the chance of progression. Surgery is generally reserved for severe curves, not mild ones. AOS describes observation, bracing, and surgery as the main proven treatment categories, chosen based on curve size, growth remaining, and progression risk. The fix is boring but powerful. Measure, monitor, move. Stay active unless a clinician says otherwise. Build strength. Don't let fear turn a mild curve into a fragile identity. And don't let random internet exercises replace proper evaluation. A mild curve is not a life sentence. It's a question your spine is asking over time. Am I stable or am I changing? Diastasis Recti. The belly can look like it never bounced back, and suddenly everyone becomes a fitness expert with terrible timing. Here's the truth. This is not just about fat. Diastasis recti happens when the two sides of the rectus abdominis, the six-pack muscles, separate along the midline as the connective tissue between them stretches. It's especially common during and after pregnancy because the abdomen expands to make room for the baby. Cleveland Clinic describes it as separation of the rectus abdominis muscles during pregnancy from being stretched. Think of the abdominal wall like a zipper. The muscles are the fabric on both sides. The connective tissue in the middle is the zipper track. During pregnancy, pressure pushes outward from inside. The zipper track stretches. Afterward, sometimes it regains tension. Sometimes it stays loose and the belly can bulge, especially when sitting up, coughing, lifting, or doing the wrong core exercise. That bulge is not a moral failure. It's a pressure problem. And the tricky part is that some hardcore ab workouts can make it worse if the core can't control pressure yet. Crunching aggressively too early can be like stepping on an already stretched zipper and wondering why it won't close. Picture a new mother trying to get her body back. She starts doing sit-ups because that's what every old-school fitness poster taught her. The belly domes down the middle. She feels confused, then ashamed, then pushes harder. That's the trap. The body doesn't need punishment. It needs coordination. Diastasis recti can cause a visible bulge and may be associated with core weakness, pelvic floor issues, or back discomfort in some people. Treatment often starts with specific exercises that rebuild tension and control through the abdominal wall, ideally with guidance from a healthcare provider or pelvic floor physical therapist. Cleveland Clinic notes that special exercises can help repair the separation. The fix is not do more abs. The fix is learn pressure management, breathing, deep core activation, controlled movement, and avoiding exercises that cause strong doming until you can control it. Severe or persistent cases may need medical evaluation, and surgery is usually a separate conversation for significant symptoms or cosmetic repair. This is not about snapping back. It's about reconnecting the system. Because your core is not a six-pack poster. It's the body's pressure control room. Unequal leg length. A person walks across the room and something looks slightly off. Not dramatic, not movie villain limp. Just a tiny shift. One hip rises, one shoulder drops, one shoe wears down faster than the other. That small difference can be real. Leg length discrepancy means one leg is shorter than the other. Sometimes it comes from the bones themselves. Sometimes it only looks that way because the pelvis, spine, muscles, or posture are changing how the body stands. That's why my legs are uneven is not one single diagnosis. It's a measurement problem wearing a pair of sneakers. And here's the twist. A small difference is common and may not matter much. The body is not a perfectly manufactured chair from a factory. It is more like a handmade bridge. Strong, adaptable, and slightly uneven if you look closely. Many small differences cause no symptoms and may only need observation. Diastasis notes that for smaller discrepancies, doctors may recommend observation or a shoe lift, especially if it affects walking, running, or back discomfort. But if the difference is bigger, the body starts negotiating with gravity. The shorter side may make the pelvis tilt. The lower back may compensate. The knee, hip, ankle, and foot may all join the meeting, and nobody brought snacks. Over time, some people may notice limping, fatigue, back pain, hip discomfort, or uneven shoe wear. Picture someone who keeps getting the same lower back ache after long walks. They stretch. They change chairs. They blame aging, mattresses, and bad posture. Then someone finally checks how their pelvis lines up when standing, and suddenly the body tells a simpler story. One side has been quietly reaching for the floor. The fix depends on how big the difference is and whether it causes symptoms. A small discrepancy may need nothing. A shoe lift can sometimes help smaller differences because it's simple, removable, and low risk. Children with more significant differences may need monitoring as they grow, and larger discrepancies can sometimes require surgery or limb length procedures under specialist care. CHOP also notes that small differences may be treated with an orthotic like a shoe lift, while more significant differences in children may need surgery. So the goal is not to make the body perfectly symmetrical. The goal is to stop one side from paying the bill for the other. Clinodactyly. Why does one pinky curve inward like it's trying to keep a secret? That curve has a name. Clinodactyly is a curved finger, most often the little finger, caused by a bone that grows in an unusual shape. Instead of forming like a neat rectangle, one of the small finger bones can develop more like a wedge. The finger follows the bone, and the tip angles toward the neighboring finger. Cleveland Clinic describes clinodactyly as a hook-like finger curve caused by abnormal bone shape, and says it often affects the pinky. Here's the important part. Most mild cases are not a problem. No pain, no lost function, no need to turn one crooked pinky into a family emergency. A mild curved finger can be like a bent tree branch. Noticeable, maybe interesting, but still doing its job. The finger can still grip, type, point, hold a spoon, and participate in all the tiny daily tasks fingers do without getting applause. But sometimes the curve is more than cosmetic. If the angle is large, the finger may overlap another finger, interfere with grip, or make certain hand tasks awkward. Boston Children's Hospital notes that mild clinodactyly usually does not cause pain or functional problems, while more severe cases may need surgery. There's also a deeper layer. Clinodactyly can happen by itself, but it can also appear as part of certain genetic syndromes. That does not mean a curved pinky equals a syndrome. It means doctors look at the whole person, not just one finger acting suspicious. Texas Children's notes that clinodactyly can be associated with several syndromes, including Down syndrome and others. The fix is usually simple. Watch function. Can the finger move? Can the hand grip? Does it hurt? Is the curve getting worse in a growing child? If it's mild and functional, treatment may not be needed. If it affects use, a hand specialist can evaluate it, and surgery is usually reserved for more significant functional problems. Not for every finger that refuses to stand in a straight line. So that curved pinky may not be a defect. It may just be a small bone taking a slightly weird route. Hallux Valgus. The bump is not the disease. The bump is the receipt. Hallux valgus is when the big toe drifts toward the smaller toes and a bunion can form at the joint where the big toe meets the foot. Cleveland Clinic describes bunions as bony growths that form when something pushes the big toe out of natural alignment toward the other toes. That means the visible bump is only the obvious part. Underneath, the foot is slowly changing its geometry. The big toe joint shifts. Pressure changes. Shoes rub. The skin gets irritated. The toe leans. The joint complains, and suddenly walking becomes a negotiation with every step. And yes, shoes matter. Tight shoes, narrow toe boxes, and high heels can push the toes into a cramped shape. The shoe becomes a tiny courtroom where the big toe keeps losing the case. But shoes are not the only factor. Foot structure, family tendency, arthritis, and mechanics can also play a role. Cleveland Clinic notes that shoes that push toes out of alignment contribute, but inherited foot type and certain conditions may increase risk too. Here's where people get trapped. They treat the bump like a simple skin problem. They put on a pad, ignore the alignment, keep wearing the same narrow shoes, and then wonder why the foot keeps sending angry emails. Pads can help rubbing. Wider shoes can reduce pressure. Toe spacers or orthotics may help comfort or alignment for some people. Cleveland Clinic lists options like bunion pads, taping, orthotics, and spacers as non-surgical ways to reduce irritation and improve support. But these do not erase the bone like a magic Photoshop tool. They manage symptoms. They reduce pressure. They slow the daily argument between your toe and your shoe. If pain is persistent, walking is affected, or the deformity keeps worsening, a podiatrist or orthopedic foot specialist can evaluate it. Surgery may be considered when conservative care does not help enough and symptoms are significant. It usually involves realigning the bones, not just shaving a bump and calling it a day. So the lesson is not Ugly feet. The lesson is force over time. A bunion is what happens when alignment, pressure, genetics, and footwear keep having the same argument, and your big toe finally loses. Which sign surprised you most? Tell us in the comments, and stay tuned for the next video by liking and subscribing to the channel. Thank you for watching.